our next session is the preventable medicine, and our first presenter would have been Dr. Mohammed Al-Ansari, but unfortunately his flight from Melbourne has been cancelled, and Dr. Ahmed Al-Rubai will do his presentation. But I'll present Dr. Mohammed Al-Ansari. Dr. Mohammed is commenced working in Australia in 2012. He underwent his physician and gastroenterology training in New Zealand at Auckland Clinical Training Network in Waikato Hospital, and Otago Teaching Hospital, London. Dr. Al-Ansari then worked in Middlemore Hospital in Auckland, New Zealand, where he underwent a research fellow position in endoscopy, during which he completed research project in capsule endoscopy and colon imaging. He received an award for the best research twice by the New Zealand Society of Gastroenterologists. He has been on the board range of interest in all aspects of gastroenterology, including inflammatory bowel disease, GORD, GI bleeding, and capsule study. Now we've got the update on the bowel cancer, which will be presented by Dr. Ahmed. Thank you.
Thank you very much. Now, part of the deal to do this presentation, Mr. Ahmed, is they add 1.5 minutes. So there'll be extra 1 minute. Because I'm not familiar with the slides. This is the first time I see the slide. Dr. Mohammed Al-Ansari, all flight canceled last night, and he was giving 4 o'clock to fly to here. By that time we finished. That's why he sent his apology. Now, you know, we're talking here about surveillance and screening at the same time. Probably we put it as screening more than surveillance, because surveillance is a gastro decision, right? But so I'll focus more on the screening. Now, everyone knows that colon cancer is one of the top 5 cancers, and in fact, the risk increases with age, to the extent 1 in 23 are affected by colonic cancer. I'm not very familiar with this slide. So now, the idea for the screening in colonic cancer came in from the fact that cancer arises from adenomatous changes, from an early lesion, which develop starting with a very small size and with a very benign type with no dysplastic changes. Now we have 2 main polyps or types of polyps with the different pathways. One is the adenomatous polyps, which are the tubular, villus, and villus. In this sequence, the faster to grow is the villus. And we have the serrated adenomatous polyps. And the pathway in terms of the genetics and in terms of the rate of developing dysplasia, then cancer, is much more with the serrated. So it's estimated that 7 to 10 years are required for an adenomatous polyp to develop into cancer, while for the serrated adenoma, the sessile serrated adenoma, as I say, it is anything around 5 years. And that's why the surveillance is different. Now, the fact that we're having those picked up early means an early detection of cancer. And all statistics support the fact that the survival is much better with the early detection. And from this, the National Bowel Cancer Screening Program as a project appeared in 2006. So this is the impact on survival. You can see it's a significant difference. Now, the National Bowel Cancer Screening Program started in 2006, and I remember very well the age cap was between 55 and 65 years, and it was trial. 3 years down the track with the study of the evidence, that was extended to include in 2015 to age between 50 and 74. And it's based on sending a kit to do the samples every 2 years from the age of 50 to the age of 74. There's no evidence that after 74, screening would add any benefit. Now, over the last 30 years, there was a trend to have more malignant lesions in the colon among young people. Young people means less than 50, right? And the increase was significant. You can see in terms of the percentage, in terms of the number of cases, it increased from 8% to 13%. That is among young people. And the mortality is higher. The reason why is, first of all, there's not much awareness that all of us think that cancer means old age. That's one. Two, symptoms arise in cases of cancer, usually explained on other bases, because it's probably unlikely to have a 25 years old guy with a cancer when he has, for example, pain or when he has anemia, right? So for this reason, we have a lot of higher mortality with the young people. Now, in 2024, the target in the National Bowel Cancer Screening Program changed to include all ages from 45 to 74. That is the program, National Bowel Cancer Screening Program. But it is also a recommendation to start the fecal occult blood testing from the age of 40 by the GP. So for the program itself, the screening starts at the age of 45. They send the kids every 2 years from the age of 45. But for the general surveillance, it's recommended that after the age of 40, the person goes to his GP to arrange for him to have second yearly fecal occult blood testing. And that's the major thing. Now, I'll come to this a bit later, but I just want to see just one minute about why we have this rise in the cancer at a younger age. One of the most important causes is the increase in the prevalence of inflammatory bowel disease, Crohn's and ulcerative colitis. And we know that uncontrolled disease in Crohn's or ulcerative colitis is a risk factor for dysplastic changes which can change into cancer. So we have for sure more prevalence of this. So that is one of the factors for this. The second factor is, believe it or not, is the preservatives and polluted food with microparticles from plastics or air. So this is an established يقولوا لي 3 minutes انا راح ابقى الى انا اخلص لان I haven't seen this. All right. So just to explain why this increase in that. While in the age of above 50, there is a decline because of the program. Now, the participation rate, believe it or not, although it is free, although the colonoscopy can be done if it's positive in a public hospital, the participation rate is low. It's never reached the target of 54 or so, 56. So that's the compliance with the test. They arrive at home, but no one done it. So that's one of the problems there. And raising awareness, particularly among our community there and the migrant community. Now, colonoscopy participation, there was a stage where the need and demand for colonoscopy for the experiment was very high, and they couldn't cope with that. That's why the priority to do colonoscopy is now priority 1. So it is category A, which means the positive fecal occult blood test should be done within 30 days. That's why now the hospitals are committed for doing this as a priority over other indications. And that's why there is this improvement in the compliance with the colonoscopy. I'll pass through all this. What to use for screening? A fecal occult blood test is superior to the DNA testing of the stool and the blood. Now, what you do, if it's positive, you send for a colonoscopy. What about after the colonoscopy? If the colonoscopy is negative, then the next fecal occult blood testing should be 5 years down the track. But if the colonoscopy is positive, then this will depend on the finding, on the polyp formation. We have certain criteria for doing the surveillance, depending on the type, depending on the number, depending on the location of the polyp.
1 minute.
أتفهم بعدين نتفهم. Now, just one thing here is a doctor put CT colonography. CT colonography is not anymore a modality to use in screening or in diagnosis, simply because it's just a diagnosis there. And the specificity is limited. Which patient to screen? Now, we said the age, first of all. Secondly, when there is family history of colonic cancer, and when there is familial syndrome, and inflammatory bowel disease for the screening. Surveillance, it depends if there is a cancer before or not. Okay. I don't know whether you'll be interested in this. This will be maybe the last slide, Doctora. So generally speaking, if you have first-degree relatives with colonic cancer above the age of 55, this wouldn't add to the risk. Wouldn't add to the risk. That's why it's enough to do fecal occult blood testing, and there is no need to do a colonoscopy. So fecal occult blood testing by the thing. But if you have one first-degree relatives less than 50, or if you have one first-degree family member with 2 second-degree family members, then you have one of 2 options. Either you do the fecal occult blood testing from the age of 35, or you do colonoscopy 10 years younger than the index case. So, yani, if the index case at the age of 50, for example, then all relatives should have colonoscopy at the age of 30. At that age. So it's 10 years younger than the index patient. Now, category 3, if you have 3 first-degree relatives diagnosed with cancer at any age, or you have 3 first-degree relatives and second-degree relatives with one of them under the age of 55, then it is definite colonoscopy 10 years before the age of the index. And that's why part of the implementation that all family members of the index case should be checked and history taken, and she shouldn't be taken lightly. Now, we have these familial polyposis. We have different type of syndromes. Usually, we start at the age of 10, sometimes 12. But in those with less severe expression, from the age of 18 to 20. In fact, one of the syndromes, we recommend resecting the colon very early at the second decade. Now, for inflammatory bowel disease, generally speaking, your patients, if the patient has a pancolitis, then after 8 years of the diagnosis, he should have the colonoscopy every 2 years. If it is just segmental colitis, then after 10 years of diagnosis, he should have every second year checking on the dysplastic changes which might appear. And this doesn't depend on the symptoms, by the way. So post-cancer resection, there's a colonoscopy 1 year after resection, if the resection is on the right side. But if the resection on the left side, probably the right side wasn't screened, that's why it should be within 6 months. So left-sided cancers, within 6 months. Right-sided cancer, 12 months. And then another one in 3 years, and then every 5 years. I think I should stop here. This is very complicated screening. Let me see if he put, I think for chemo prevention, there is nothing established. So the aspirin, there is a soft evidence that using the aspirin delay the progress of these plastic changes, but we don't use it routinely. Some NSAID also mentioned. Waqfat, Doctor, when she stands, she's very, very scary. Very scary. When she stands, very scary, yeah. Okay, just finish, Doctora. There is no evidence that screening or surveillance after the age of 75 will alter the mortality. I think that's all procedure for me. Thank you very much, and sorry for that.